Hi, listeners. It's hard to believe, but New Frontiers in Functional Medicine has been going strong since 2015. With over 200 episodes and over 2 million listens, we are growing every year. My goal is to continue to bring you the best minds in functional medicine, epigenetics, and longevity. I want the content to be actionable for the functional medicine clinician and interesting for the rest of us. Thank you for supporting this podcast with your likes, with your honest reviews, with sharing the episodes with your friends and family. And if you haven't done so, please consider leaving a like or leaving us an honest review wherever you've accessed this podcast. Thank you, thank you, thank you to our sponsors. Because of our sponsors, these are companies that I trust, that we vet carefully, that we use in clinical practice, that I use personally. Because of them, everything associated with this podcast is free. If you haven't done so, I suggest you head over to drkfitzgerald.com to the podcast page where you can access the full transcript for every single one of these 200 episodes. And along with that transcript, you'll get an episode summary. You can get the research citations and additional content that is pertinent to the episode. I myself return to the transcript page all the time to pull out a little snippet of information that I want to recall or access a citation. Or better yet, sign up for our newsletter, again, at drkfitzgerald.com, and every single podcast episode will drop in your email as soon as it's released. Thanks again. Hi, everybody. Welcome to New Frontiers in Functional Medicine, where we are interviewing the best minds in functional medicine. And of course, today is no exception. If you're joining me here on YouTube and you can see who I'm with, of course, you know this human being. He is just a treasure in the functional and integrative community. He's a mentor to me, as he is to many, 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 many of us. And so I'm just delighted to be talking to him today. I'm with Dr. Mark Houston. Dr. Houston is a clinical instructor at George Washington University. He's also the director of the Hypertension Institute in Vascular Biology and medical director of the Division of Human Nutrition at St. Thomas Medical Group, St. Thomas Hospital and Health Services in Nashville. He is on faculty at FAARM, FAARM, and the Metabolic Medicine Institute and George Washington University, and he directs the cardiovascular modules. He's also published 7 best-selling books on vascular function. Dr. Houston has an active clinical practice. He teaches all the time. He does clinical research at St. Thomas Medical Group and Hospital, and he founded the Hypertension Institute in 2000. Dr. Houston, welcome to New Frontiers.
Thank you, Kara. It's a pleasure to be with you today.
It's always great to be able to spend time listening and being educated by you, Dr. Houston. I'm excited to be talking about it. We're talking about cardiovascular disease, of course, something that you're incredibly well versed on, and you've been, at the front of teaching us in integrative and functional medicine. What determines our risk for cardiovascular disease?
Well, everybody points to the fact that genetics are important, and they are, but I think that environmental influences actually can trump the genetics if you know how to manage what's called gene expression. So, the usual things we talk about is lifestyle, dietary, nutrition, exercise, the typical risk factors, blood pressure, cholesterol, diabetes, smoking, etc. But I think if we just make it real simple to say that genetics can now be measured, you're not stuck with your genetics so that you're doomed to whatever they say you have, because we can turn the genes on and off and modify cardiovascular risk. And then most every risk factor that we have now is easy to treat. We've got good drugs, we've got good nutritional supplements, and the integrative approach now, which is what we do at the Institute, really has allowed us to manage anything in cardiovascular disease to, I think, an optimal degree.
That's an incredibly optimistic outlook. I mean, I love it. It's very uplifting. It's powerful. So in your mind, it shouldn't be a leading killer by any stretch.
Not at all. I mean, we know that it is right now in both the United States and worldwide. CVD is the #1 cause of death. Stroke and MI are the top cardiovascular reasons for death. But the point I want to make is that if we identify patients early,
Mhm.
I'm talking about, pediatrics here for sure, maybe not even even earlier than that. I don't see a lot of pediatrics, but when they're teenagers, I'm starting a very aggressive identification program, prevention program, and treatment program. Because I really believe if we do the things that we're going to talk about today, we could reduce the risk of cardiovascular events in this country by, and I'm being optimistic, but 70 to 80%.
Extraordinary.
Yeah.
What's the best predictor for the cardiovascular event?
The two best ones that we use in the Hypertension Institute for, I would say, coronary heart disease risk, which is the precursor for myocardial infarction, would be coronary artery calcium scoring.
Mhm.
And then another test we do that measures arterial elasticity. So we're looking at both a function and a structural issue. There's a lot of other things to do, but if you did just those two things in patients, you could really pick up early disease and start treating it.
Awesome. Awesome. All right. Well, let's get into how we're going to begin to how we want to address early disease. Actually, we can talk about disease across the spectrum, but specifically, I want to talk about the 2023 paper that you published looking at nitric oxide. So just introduce the use of nitric oxide, benefits, utility, efficacy, and then what you guys looked at and why what you did was really something different. You demonstrated something pretty cool.
Yeah. So one of the very basic molecules that drives cardiovascular disease is nitric oxide. Now, don't get that confused with nitrous oxide, which is what you get in the dental office. Nitric oxide it's a gas and it doesn't last very long. You can store it in your body and then kind of pull the bank nitric oxide out when you need it. But it won the Nobel Prize in 1996, and it's related to anything you can think of related to cardiovascular disease, whether it's myocardial infarction, coronary heart disease, stroke, congestive heart failure, renal disease, and other things. And the primary role of nitric oxide is to vasodilate the arteries. It has antioxidant effect, anti-inflammatory, immune function, and a host of other things. And maintaining a good nitric oxide level is one of the key things to prevent CVD. And it's one of the things that we measure in the office. That test I mentioned where we're measuring arterial elasticity. And there's other ways you can do it with, there's strips you can use under your tongue, and there's blood tests that measure it well. But the functional test for nitric oxide, which is called pulse wave velocity, arterial elasticity, is one of the best ways that we can identify adequate levels of nitric oxide that are in fact bioavailable.
And so, I mean, in your population, do people generally have adequate nitric oxide? I mean, I'm going to guess probably not.
No, you're right, Kara. Almost
Yeah.
everyone has adequate nitric oxide levels unless they're taking, a nutritional supplement that raises nitric oxide. There are a few drugs that do it, but they don't do it as much actually as the nutritional supplements do. But when we measure that, I would say 95% of people that come into my office have very low nitric oxide levels.
That's extraordinary. And does it track with hypertension, or you're going to see it drop initially?
It tracks with hypertension particularly, because the earliest finding in hypertension is stiff small arteries. It's called the C2 compliance. And if you have stiff small arteries, almost all of those patients are hypertensive. And then the large arteries are next to go. And then when you have those two arterial systems in a stiff format, the risk for all those CVD problems will go up dramatically.
Even in a healthy diet, there's inadequate nitric oxide.
Yeah, it's very difficult to get nitric oxide levels up just with dietary means, although you can do it. but it requires a lot of dark green leafy vegetables like kale and spinach and beets and grapes and other things like that. And if you eat a really good diet like that, then your nitric oxide levels may in fact be normal. But most people, as you know, don't follow that kind of nutrition program.
You need to be eating, when you say good amount, they're substantial
Yeah, we're
servings.
talking, 10 servings a day of fruits and vegetables.
So even those of us who are mindful are not going to be hitting that all the
Probably
time.
not,
We're
yeah.
just not going to be hitting it. So so I guess that could explain the fact that I think 50% of Americans are hypertensive.
Yeah, that's about the right number. If you look at 140 over 90 is kind of the break point between normotensive and hypertensive. It's right at 50% of the US population that have high blood pressure.
Extraordinary. All right, that's extraordinary. Well, I want to bring us back to the study. There's a ton of questions I could ask, and we'll circle back to that, a little bit later on, just kind of thinking about nutrition more broadly. But let's talk about what you did in the study. You used a product called Vascanox. You noticed, actually, extraordinarily enough, that Vascanox immediately increased nitric oxide, and it actually hung around for a while. So walk us through what you did in the study, what the findings were, and the intervention that you used.
We took a group of mild hypertensive patients. We gave them Vascanox 2 capsules in the morning. The patients who got Vascanox had immediate increase in their nitric oxide levels as measured with a strip.
Mm-hmm.
And then they had immediate reductions in blood pressure, both systolic and diastolic. And those reductions were persistent for a full 24 hours. And then we redosed it, and the blood pressure over a period of time continued to actually decrease to a significant level that actually was similar to a single drug therapy that we would use for hypertension. And it was highly significant. What was interesting is that the higher the blood pressure was higher the blood pressure at start of study, the greater the reduction was percentage.
Wow.
And the importance of that is if you have, for example, normal blood pressure and you were to take the Vascanox, you probably won't see much of a change in blood pressure, which is good because you don't want to drop it if it's already normal.
Mm-hmm.
And we didn't see anyone who had high blood pressure drop to a level that would cause hypotension or clinical symptoms of low blood pressure. It seems to kind of modulate the blood pressure into a very safe range, but it's very significant, the reductions that occur.
That's extraordinary. And, to your point, it's a single dose. I mean, other nitric oxide stimulating or producing products. The half-life. Talk about the half-life of nitric oxide and why it's remarkable. This worked in a single dose, and why it did. Like what's the mechanism that allows that sustained
your
activity?
question is exactly correct. Most of the previous nitric oxide promoters were very short-lived. They would peak at a high level, perhaps, but then they were gone very quickly. In fact, most of them would be gone in 4 hours, and they would drop below what's called a therapeutic threshold of nitric oxide. However, when we compared Vascanox to other nitric oxide promoters, the peak level of Vascanox was about 4 times greater than any of the others. And its half-life, so to speak, or the level to which it maintained above a certain threshold for nitric oxide, lasts for a full 24 hours. It did not drop off quickly. In fact, the end of 24-hour level of Vascanox was higher than a lot of the 4-hour dosing of some of the others of nitric oxide promoters.
That's incredible. And I just want to link that to the earlier statement that you made that despite this pretty extraordinary spike, it didn't drop some of the, so these were mild hypertensive. So some people were on the higher side and some people were, pretty close to normal.
Right.
Those close to normal folks did not become hypotensive, even though they had, measurable good amounts of nitric oxide present.
Yeah. So there basically were no side effects at all during our study.
That's awesome. That's so interesting to me. And the ingredients in this product that allow it to hang around for a while.
Yeah, it's a very unique combination, and we could talk about I think the two primary ingredients that make it work. It does have a lot of things in it though that increase its effectiveness. But you've got the nitric oxide promotion, and then you have a substance that blocks the breakdown of the nitric oxide, and that's a hydrogen sulfide compound, which is derived from a form of garlic. And it's so unique. It's the only nitric oxide supplement on the market that has that combination.
So then would this be appropriate in erectile dysfunction? Might we consider using it?
Yeah, in the clinical practice and also in the study, there was actual improvement in sexual dysfunction.
That's really interesting. So some of the folks in the study were had diastolic hypertension, some did not. Vascular effects were different in these two groups. There's actually an interesting population. So some were closer to normotensive, diastolic BP was decent. There was somebody who was a little bit treatment resistant. I'd be curious about your thoughts on that individual who didn't appear to respond. So diastolic normotensive, diastolic hypertensive, just the population group and some of the interesting things you found. Walk us through that.
Right. So systolic and diastolic hypertension are totally different animals. Diastolic hypertension generally is an abnormality of the small resistance arteries, which we can measure with this machine that I mentioned. Systolic hypertension tends to occur as you get older, and that's when the large arteries tend to get stiff, like the aorta. So both of them are important in reducing cardiovascular risk. And what we found is in the study, if we took the hypertensive higher end versus those that were more borderline, there was a huge difference in the response rate. I alluded to that earlier, that the higher the pressure at the initiation, the more reduction we had in both systolic and diastolic. Whereas if you looked at those that were in the very mild range, there could be a difference between the systolic and the diastolic blood pressure. So it's not so much a resistance effect as it is, I think, the level of blood pressure when you start the Vascanox and how it's going to respond depending on arterial resistance and probably age.
Mm-hmm. There was one person who didn't respond at all. I'm just curious your thoughts on that individual.
There can be a rare patient maybe that has an arterial system that is so stiff that it takes them 3 or 4 months to get that corrected. Whereas most people, their arteries respond quicker. And if you get the large and small arteries both corrected at the same time, that's you get the most dramatic reductions in both systolic and diastolic. But there are those cases, and I have a lot of those in the office that are, we call them vasculopaths, meaning that their arteries are so stiff that they just take longer for things to become more elastic.
Okay. And you would still do a lifestyle approach, but obviously, you're going to be using medication as appropriate and, more aggressive interventions.
Absolutely. I think you have to always integrate your antihypertensive program. You want to use nutrition and lifestyle combined with good supplements and drugs to get that maximum effect.
You've talked about 2 of the tools that you're using in office to evaluate blood pressure. What else are you looking at and where do you start? How do you evaluate blood pressure in your practice?
We have a whole host of non-invasive cardiovascular tests. So we have the EndoPAT, which is for endothelial dysfunction. We have the HDI profiler, which is small and large artery arterial compliance. We have a plasmography, which looks at overall cardiac function related to coronary heart disease, residual blood volume in the coronary arteries, elasticity, 2D echoes, carotid duplex, of course, your typical stress test, but we use a test called CPET, which is cardiopulmonary exercise test, which measures both cardiac and pulmonary function at the same time. And the coronary artery calcium scoring, which tells you how much calcium you have in the entire arterial system. And then we do the more sophisticated tests, but that's kind of the baseline that almost everybody gets. Depending on what those show, we may go to more sophisticated testing later. One of the newest tests that we're doing, once you identify high-risk patients, it's called CCTA. That's coronary CTA with a FFR, which is a fractional flow reserve, and Clearly, which is a artificial intelligence analysis of soft plaque and hard plaque and degree of stenosis in the coronary arteries. It's almost as good, if not better, than a coronary arteriogram.
That's incredible. That's a very robust analysis. I'm excited about the use of AI in some of these imaging. Yeah, clearly is something that we're bringing into our practice as well. Thinking just like who needs this kind of investigation? I mean, I would imagine that probably all of us, at a certain point, or actually you're starting in some cases with adolescents, like when do we actually, should everybody get this evaluation regardless of what their blood pressure is? And when should we get it? Like who's appropriate candidate for this?
Yeah, it's a great question. And of course, I would probably answer that maybe differently than most because I'm very aggressive in cardiovascular testing and early detection. So I think that the cost benefit of doing these tests, even in a very early population, is very good because if they're all normal, hallelujah, you don't have to worry about it for a while. But if you have a 17 or 18-year-old person in your office and any of those tests are showing abnormalities, then those people are at high risk, and you've identified them at a stage you can actually start to do something to prevent them from developing hypertension or coronary heart disease or some other complication.
Yeah, I mean, that could be highly motivating. I mean, it just seems to me as, we're putting more and more attention into prevention, optimal wellness, et cetera, that this kind of investigation would be, I mean, it'd be fabulous to do it in younger individuals and that, but at least 40s and 50s for a start, a nice evaluation.
Right. And I think the one of the take-home points I would want to leave with your audience is aggressive early detection and early aggressive prevention and treatment is the only way that we're going to ever reduce cardiovascular illness in this country and worldwide.
Amen to that. All right, let's go back specifically again to blood pressure. There's a concept called nocturnal dipping, and that we actually want to see it. Actually, let me back up from that. Gold standard for evaluating blood pressure is 24 hours. So talk about how you do that specifically. And then, the variation we might see through that 24-hour cycle, what's normal and what's not normal.
Right. So typically when you have your blood pressure checked, it's going to be in the office by a nurse or a physician. And then you may do a home monitoring with one of the automated cuffs. Those are great for that reading at that time. However, those do not evaluate things that are important over 24 hours. So the gold standard, as you mentioned, for hypertension evaluation and treatment is a 24-hour ambulatory blood pressure monitor. So what things do you get that you don't with a regular routine once in your office testing? Well, you get what's called nocturnal dipping, which you mentioned. You also get nocturnal blood pressure. You get lability of blood pressure. You get AM rises, and that is how quickly does the pressure go, what level in the early morning hours, which is when most people actually have strokes. The nocturnal dipping means that your average daytime pressure is 10% different from your average nighttime pressure. So that means you have a 10% dipping at night, which is important to let the arteries speak so it'll relax and get the pressure off the arterial wall.
Mhm.
So dipping is important, but also the actual level is important. And that's what you call nocturnal blood pressure. They're two different things, both important. So the actual level and the 10% dipping are the two things that drive the risk for heart disease. And that's why you have to do a 24-hour blood pressure monitoring. You can do all the other things in your office, but the number one driving force for stroke, heart attack, heart failure, and kidney failure is dipping status and nocturnal blood pressure.
Associated with an AM spike? It's
Well,
the
the AM spike is important, but if you look at all the criteria that you get with a 24 ABM, number one is nocturnal blood pressure, and number two is dipping status.
that's fascinating. And so if we're not doing this kind of investigation in office with our hypertensive patients, we should be referring, and then, but barring being able to do that, I mean, what do you suggest?
If you're measuring blood pressure a lot in your office and you want to really find out how bad it is and how to treat it, you can purchase a 24 ABM for a reasonable price. You can get used ones online for probably $1,000 to $1,200, and they're reimbursable through insurance. The other important thing about the 24 ABM is not only does it help you diagnose nocturnal dipping and nocturnal hypertension, but it also tells you how to treat. That's an example.
Yeah.
How would you know when to give their antihypertensive medications? Well, you don't. It lets you know your dipping status. And here's the example. If your dipping status is abnormal, in other words, you don't have that 10% dipping at night, what time of day should you give your blood pressure meds? Well, you should give it at night.
Mm.
However, if you're a normal dipper, you would prefer to give it in the morning so you don't drop the pressure too low at night. So the two things you get, well, not more, there's more than two, but two most important is the diagnosis of blood pressure issues with dipping and status. And the second is what is the timing of your medications? What's the diurnal rhythm, circadian rhythm when you give medication?
I mean, I'm imagining we're gonna miss a lot of these nocturnal shifts just by taking an in-office pressure.
Yeah, you can't. There's no other way to get it. So if you really want to practice important state-of-the-art hypertension, you have to do a 24 ABM in your patients.
Right. How many, I mean, just out of curiosity, like how many BP patients would you miss by doing an in-office measure? Like how many of those extremely
Lack of nocturnal dipping is very common. I just looking at my practice, I say at least 50% of the patients don't dip.
wow.
You're gonna miss a lot of people.
And they're on this, and that's not going to improve if you miss them. I mean, that's just going to worsen
Right.
over time, I would
It
imagine.
won't get better because you might not give the right medicine, or you might give it the right time of day.
Yeah. So clearly many of these prescriptions are going to be indicated for a lot of the changes, the pathological changes that you're describing, but we're going to be thinking about, lifestyle interventions too. You've talked about Vascanox. What are some of the other lifestyle interventions you think about?
I want to say one important thing that people need to recognize because it's not emphasized enough in the literature. When you have recognized hypertension that's defined now as sustained or chronic, you must start a drug immediately to get their pressure under control, because there's clinical studies that show the longer you wait, the more adverse events you'll have, and you never catch up. You don't say, okay, well, your blood pressure is 140 over 90, and we're going to give you 6 months of natural lifestyle changes to see what happens. You don't. You start them on drug therapy immediately, and then you add lifestyle changes to that regimen to add to the blood pressure reducing effect. Now, the lifestyle changes are things including low sodium, high potassium, high magnesium, supervised exercise program, weight reduction, tobacco cessation, controlling of inflammation, oxidative stress, different levels of things you check in your blood, like homocysteine and C-reactive protein. And then you do a physiologic measurement of what's causing their blood pressure, and of course measure, their elasticity issues. But all those have to be addressed as part of the composite program that you integrate to manage hypertension. And there are two goals in treating hypertension. One is to get the blood pressure to 120 over 80 or less. The second is to change the function and the structure of the arterial system to make it healthy. And those two can be independent of each other, depending on what you're using for drugs and what you're using for supplements.
What's an optimal blood pressure in your opinion?
You would want it at 120 over 80 most of the time, with appropriate nocturnal dipping and appropriate nocturnal blood pressure. You can go lower. 110 over 70 would be probably where you get to the flat line, but that's a hard goal to reach in most patients. I'm perfectly happy when I can get a pretty good sustained 120 over 80 with a 24 ABM with good dipping status.
And what do you expect to see as a good dipping status number?
You try to get as close to 10% as you can, but not go over that, not go under it. Obviously, it's very hard to hit it at 10% every time, but if you get as close to 10% as possible, and then look at the actual nocturnal blood pressure at the same time, it's pretty easy to identify with the ABM exactly where you need to be, and then you adjust your medicines and supplements around that.
Are you layering Vascanox into the care program for most of the patients that you're seeing?
Yeah, we do. What we do is we measure their nitric oxide levels with the strip, and we measure it with the machine, and then we measure blood called ADMA, asymmetric dimethylarginine.
Yeah.
And those three will tell you exactly kind of where you are with your nitric oxide. As I said, almost everybody's low. So it's important to go ahead and give them Vascanox as part of the initial regimen, which you start on day one, along with the drug, because that way you hit the blood pressure level and you also hit the arterial elasticity issues at the same time. So the drugs are going to lower blood pressure. Certain drugs will improve nitric oxide, but they're not as strong actually as Vascanox. Vascanox will improve the arterial elasticity, and it also helps support the blood pressure.
It's a really interesting product. I think, again, just to reiterate that, adherence it's easy with it because you only need to take it once, and you'll have that sustained benefit over time, as we described in your study outlines. Incidentally, folks, on our show notes page, we will be linking to the study. It's a free full text, so you can check it out yourself. I eat a pretty plant-dense diet. I've got a big bowl of greens here to tuck into after we're done recording. And when I did my salivary nitric oxide, it wasn't great. I expected to see it, nice and purple, nice strong nitric oxide. It was there, I had some, but I didn't have a lot. So to your point, I think, probably some of us eating what we would consider a pretty impactful diet may need some extra support.
Yeah, which brings up another good point, which we hadn't talked about. After age 40, the regular system by which you make nitric oxide through arginine and citrulline
Yeah.
is not working well with the eNOS enzyme. Most of your dietary nitric oxide is through food after age 40. So you've got to get, the dark green leafy vegetables, the beets, and other things to get your nitric oxide levels up. But here's the problem. Even with a good diet, if you
Yeah.
use mouthwash, if you're taking a PPI, if you're taking an
Right.
H2 blocker, you knock out the entire nitric oxide. You've got a bad microbiome in your mouth, a
Yeah.
bad microbiome in your gut. You don't make nitric oxide. If you don't have gastric acid, you don't make nitric oxide. It's a very complicated pathway. That's
It's,
one reason a lot of people don't have good levels. Even though they're eating good, they're taking certain medications that will adversely affect their NO levels.
yeah, of course. I mean, who doesn't have some degree of dysbiosis these days? And I'm measuring the oral microbiome more and more as well. And so I appreciated your discussion in the paper on the key players in the oral microbiome who are, helping
Yeah.
us produce nitric oxide.
Yeah, I mean,
And,
you
and
switch Listerine once a day, you're done with your oral microbiome.
right. And I would not be surprised even if, those of us not using Listerine have damaged it in some other way, so yeah, that certainly, yeah, it's just fascinating how essential the oral microbiome is. Yeah, and PPIs are our top drug in our country. Many of our patients are on them. So yeah, down the line, we can see how it interrupts. What about just using arginine or citrulline? Do you use those
So,
in practice
no,
these days?
I have totally gotten away from arginine and citrulline. A lot of reasons. Most people are not arginine deficient, and if you give arginine, you've already saturated the enzyme. It doesn't do anything. In fact, it can give you a bad pathway called peroxynitrate by taking too much arginine. You don't usually get that with citrulline because you kind of go in the back way. But I don't find those to be effective usually in patients even before age 40. So I don't typically use them anymore. I'm going to go straight to Vascanox if I want their nitric oxide levels up at any age, actually.
Yeah, I remember there was a sustained release arginine out. I mean, we were really around the time we started using ADMA as a measure. I know we were thinking about, arginine and sustained release arginine, but I'm with you. It wasn't sort of the success that I was hoping that it would be. Yeah.
Exactly.
Arterisol is another cool product from Calroy. And I know you're a medical board member over at Calroy. I mean, you're really familiar with the products, you're researching them. Are you using why don't you just tell me a little bit about Arterisol and if you're using it in practice?
Arterisol is a glycocalyx promoter. Glycocalyx is the layer outside the endothelium that protects the endothelial lining. The glycocalyx is very similar actually to endothelium. It's got nitric oxide in it. It's got antioxidants, all kinds of great things that help to improve vascular health. And Arterisol in our clinical trial also was great in supporting blood pressure. It's a great add-on to use to Vascanox in patients who need an extra boost in their nitric oxide levels or an extra boost in their overall prevention for cardiovascular events and health. And we use them together all the time. And it's easy for me because I have this machine that measures their arterial resistance. So I can say if they come back in 3 or 4 months, arterial elasticity is better, but not where it should be. We keep them on the Vascanox, and then we'll add the Arterisol to it. And most everybody, I'd say close to 98% of people will respond to the two together to get their arterial system under control with those two.
Are they long-term? Do you keep most of your patients on them long-term?
Typically, yes. I would recommend long-term use of both. And the reason for that is most patients, as they get older, are going to lose nitric oxide levels. Their arteries get stiffer, their risk for CVD goes up. So you're better off taking something that's going to help prevent cardiovascular disease by keeping your arteries healthy. And by doing that, you're going to maintain good arterial and vascular health without having a lot of side effects.
That's what I was going to just bring in. The long-term use is there's no falling. Yeah.
And you can use Vascanox or Tiercel routinely with virtually any drug. There's hardly any contraindications or drug interactions.
And then to the earlier point, you talked about, we're not worried about, hypotension. You haven't seen that.
You don't get hypotension in patients, even though they're normotensive to begin with.
Okay. You talked a lot about the tests that you're doing, blood, and some of the imaging and function tests. If you only have 3, like where you may have already covered this, but I'm going to ask you again, like what would be your top 3? For those of us in clinical practice we don't have a Vascular Institute at University of Tennessee. Like those of us in clinical practice who want to do a good job, we want to do right for our patients, but we have more modest tools.
Yeah. So if you're talking about what would be your top 3 non-invasive vascular tests, I would say coronary calcium scoring, which you get done anywhere for about $50.
Yeah.
Second would be the HDI profiler, which measures arterial compliance. There's a lot of ways to do that. You can purchase the machine, you can lease the machine. It's was developed at the University of Minnesota, still available, and it's very highly effective. And that one actually not only measures arterial compliance, but can indirectly give you a good effect on endothelial function. Now, the third would be an option. You can get an endopat, which is going to measure endothelial function directly, or you could do a plasmography, which measures sort of the overall cardiovascular function indirectly. It gives you some really great information. And those machines are not that expensive either.
What about like a carotid intima media analysis?
Do those. I recommend them. Problem is, by the time you have carotid intimomedial thickness or plaque, you're way past the prevention stage. You've already developed structural disease in your carotid arteries. So I would do it, and again, it could be a close third or fourth to the things I mentioned. Most people in any office can do those by contracting with another company. You don't have to buy the machine, so you can still do that. And also the other would be a 2D echo, which you can contract with another company. So you don't have to buy an echo machine or become a echo reader. You can always kind of farm those out. So those 2 can be done easily. The others you would probably have to have actually in your office.
And we've created some nice partnerships in our practice. We're in Connecticut, and so there's decent providers relatively close by. So clinicians can do that as well. All right. Well, what about blood tests then? Same question.
Yeah, blood tests. I would say number 1 would be an advanced lipid profile, where you're getting particle size and particle number. And then you definitely want to measure inflammation in some format. C-reactive protein is probably the easiest to do. And then a good chemistry profile where you're going to be measuring renal function, microalbuminuria, for example, with a urine sample, blood tests on creatinine and blood sugar to make sure they're not diabetic, homocysteine level. All those can be included in a nice Chem 12 profile.
Are you getting ADMA routinely in your patients?
Yes, I do. I get it through Cleveland Heart Lab as part of the routine initial profile. I have an oxidative stress, immune function, inflammation profile that I organized through Cleveland Heart Lab. Is specified to what I want, unique to my practice. And we measure about 15 different things, including ADMA.
Okay, good. We might be able to actually just plug into Cleveland Heart Lab and ask them to pull your panel out for us.
Yeah, you
can
do that. course.
do what you're doing. Just copy
All right.
it. It would be a whole nother conversation. I'm dying to ask you about reference ranges and like what you're going for there. Do you want to just make a quick comment on that? Because I know it's in people's mind,
Yeah.
Peter and
Well,
Tia have
I
like
can give
blown,
you I
yeah,
can give you some easy ones that will
yeah,
remember.
yeah.
C-reactive protein less than 1.
Okay,
Okay, that's a good information
yeah.
marker. LDL for a patient who has not had heart attack would be 100.
Okay.
And then we measure the particle number, which would be less than 1,000. So like a 10 to 1. Okay.
Mhm.
And then if you measure microalbumin in the urine,
Mhm.
it should be 0. And that's a great marker for future cardiovascular events, but also kidney failure.
Yeah. And what about ApoB? People clinicians and patients alike are talking
Right.
about it.
So ApoB is one of the things you get on the advanced lipid profile.
Mhm.
And ApoB is a composite of all the advanced cholesterolgenic, atherogenic particles in your system. But with the advanced lipid test, the ApoB probably should be less than 70, but it correlates very well with lipoprotein particle number, LDL particle number. And the particle number actually is a little bit better than the ApoB, but you get both on the advanced lipid test.
What about LP little a? If you're seeing somebody with LP little a, we know I know I'm just diverging here, Mark, but you see somebody with LP little a, half of my family has pretty markedly elevated LP little a. I'm fortunate that
You
I
didn't.
escaped that. Yeah, about my
Right.
dad, two of my siblings. And so we're going pretty aggressively after everything else that we can. I'm curious. your
Right.
thoughts on
LP little a is it is also measured on the advanced lipid test. You won't get it with routine profile,
that.
so you'll miss it. So it's important that you measure advanced lipids. LP little a, as you pointed out, is genetic. We're not sure of the actual incidence in the population, but it's probably 20 or 25%. It's pretty high. And it causes thrombosis and it causes plaque formation both. It's very hard to treat. Um, the only thing that treats it well right now is the PCSK9 inhibitors. They'll drop it at about 30%. Niacin, maybe 15 to 30%, depending on the dose. Outside of that, we don't have anything yet, but there's several drugs being developed that reduce Lp(a) by 98%, which are supposed to be out in 2024.
Incredible. All right, well, we'll be paying attention to those. For this population, when you're looking at lipid panel and you see LP little a, of course, we need to go after them again with the drugs, and we're not saying that we don't, but I mean, arterisol in this population strikes me as a no-brainer, and and Vascanox as well. What are your
Well,
thoughts?
both of those would improve arterial health, but neither one of them have been shown to reduce Lp(a).
Right. So
Yeah.
yes. So let me, I realize that we're not changing LP little a, but we're doing everything around it.
Right. I mean, I think your point is well taken that when you have vascular disease and you have something that's hard to treat,
Yes.
you do your best with that one, but also support all the other vascular issues that could contribute to a heart attack and try to minimize those.
That's right. So this is actually, we're kind of coming full circle in the question, so sort of, it's good that we ended with the conundrum of LP little a. It's the top cause of death, cardiovascular disease. It's just this huge, we can't understate how extraordinary the risk is. And I see it directly in my family. My grandfather died of a massive heart attack. I'm certain he had elevated LP little a, as my dad does, his father. And I see in my siblings, and we're really paying attention as best we can here to everyone. You started our conversation by really giving some positive thoughts around how we don't need to, this does not have to be our cause of death. So even though it is everywhere and it is the #1 cause of death, I mean, this doesn't have to be what kills us, that there are plenty of nutritional lifestyle interventions. There's things that we can do, you know, again, to your point, in adolescence, or, you know, with our newborns, like, and on, like the cycle of life. Like, what do we need to be doing, you know, so that we can, you know, absolutely not have this be our death sentence?
Well, for me, as an adult internal medicine cardiologist, obviously I wouldn't be seeing patients till probably around 13 or so.
Mhm.
But I would be doing the tests that we've talked about in those patients. I would start aggressive, non-invasive cardiovascular testing with all the different things we talked about, with an extensive blood panel, et cetera. And based on their family history, I would get some genetics as well. And once I have that, I know exactly where they're heading. Are they in trouble now, or will they get in trouble soon? And so you know when to start seeing them. They'll need to see them every 3 months or every year to make sure that we start treatment of something before it gets out of hand. If you're a pediatrician, you know, that's not to say you shouldn't also be doing some of these things, because you may have somebody who's 8 years old who has horrible family history, and you need to start treating them early because they may already have problems that are beginning to cause vascular disease. You know, one of the old adages that I throw out, people laugh at when I say this, is when does vascular disease start? It starts in utero.
As does dementia. You know, I was interviewing David Perlmutter, and that was his answer.
Yeah.
Starts in utero. Yeah. Right. Yeah. So we actually need to start before preconception.
Exactly.
Well, listen, I mean, I've known you for my entire career, and you walk this walk, you know, you walk this walk. You're not just, you know, you're advocating pretty aggressive interventions and analysis and testing, but you're just one of the healthiest people who shows up at a conference. I mean, it's true. I mean, you're about to go and teach. You just told me, you know, off before we hit record, you're going to go do, you know, as you have been for many, many years, 24 hours of teaching to physicians at FAARM in December, and you've been doing that for a long time. Like, I mean, what are some of the, what do you do? What are some of the things that you absolutely adhere to in your life to stay healthy and strong?
Well, you know, if you were to pick a few things that would try to keep you as healthy as possible, getting 8 hours of sleep every night, of good sleep, an hour of aerobic and resistance exercise daily, a Mediterranean Predimed type diet, which is going to be 10 to 12 servings of mixed colored fruits and vegetables every day, maintaining an ideal body weight with a body fat for a male of 16%, for a female of 22%, and then doing all the things I do to everybody else to track my cardiovascular stuff and get all those risk factors under control. And obviously don't use any tobacco products at all.
Yeah.
If you did those things, you could probably make it to 123 years, which is what Jean Calment made, the little French lady who got to, I think, 123 or so.
Yeah. And
Yeah.
you're not going to Starbucks and eating one of those giant, like, purple, green, and yellow Frappuccino, ultra processed yada yadas. I don't think I've ever seen one of those in your hands.
No, I don't drink any caffeine whatsoever, except maybe for occasional herbal tea.
That's as risky as you go.
Yeah, risky.
Well, I have to say, it's just been a real delight talking to you.
You too,
Doctor.
Tara. Yeah, I
Yeah.
appreciate you having me on your show.
And I look forward to seeing you in person and giving you a real live in-person hug.
There we go. Look forward to it. We'll get Andy to set something up for us, maybe. Huh?
Yeah, absolutely.
Awesome.
Thank you so much.
Thanks, Kara. All right. Have a great day, dear.
You too.
Bye-bye.